Yeah, so I'm Dr. Randy Blome. I'm a family practice doctor at the Confederated Tribes of Grand Ronde, and thank you for having me here. One of the fun things of doing a talk like this, you get to show a slide like this. So this is me at Buoy 10 fishing in Astoria. I'd never been to this facility. We're right by Tillicum Crossing. Tillicum is, of course, the Grand Ronde word for people. So Jude asked me here for two reasons. One, she wanted you all to get a chance to hear from somebody that's in Indian health. And it was really important to her that we in Indian health would have a voice. And so we really appreciate that. I'm here, by the way, with Kara Hook. She's one of our pharmacists, and she's part of my Hep C team. And then Eric Vinson is part of Northwest Portland Area Indian Health Board, which is a terrible acronym. It should be shorter. But they do a wonderful job. I always have a hard thing. So I have just like a few really clear messages that I have. And one of the messages I have is that Hep C is not going to get solved without primary care. So Andy and I were kind of grouped together. We're both primary care physicians, and we're both treating Hep C. So this lady had asked the question about, hey, what about the linkage of care? We need to have primary care. That's one of the points that I really feel strongly about. So I'm going to just real quickly, the National Indian Health Board, you may know they're in Washington, D.C. They're a Department of Health and Human Services. The kind of interesting thing, there's 566 federally recognized tribes in the country, and they represent them. They divide the country into 12 regions. We're in the Portland area, and again, the Portland Area Health Board has been interested in hepatitis C for a long time. They do a wonderful job. If you ever went to their website, everything you need to treat hepatitis C, it's amazing all the things that are there. This is their long acronym. In Oregon, one of the things I just want you to know, there's 9 federally recognized tribes. We're from Grand Ronde. I think here's a map. You can see just focusing on that. Some of you, if you're not involved in Indian health, may not know that OHA has a special person who's a liaison. I think they're under Pat Allen, and they're a liaison to the tribes in Oregon. And then in several departments, there are people who are liaisons to the different tribes. And I want to talk a little bit about our clinic. We have a wonderful clinic in Grand Ronde. In one building, we actually have a dental clinic, an optometry clinic, our medical clinic, a busy pharmacy, behavioral health that has both counseling and alcohol and drug treatment. And then we have community health nurses that are, they're like health educators. If people have worked in migrant clinics, they're a lot like the promotorios. And we have RNs that do house visits. And they have been an important part of our reaching out to the community. So one interesting thing when you're a tribe, we're a sovereign nation. We have a degree of self-determination that maybe other people don't have. And so a lot of tribes have adopted this idea of micro-elimination a long time ago. And so the vision that we have is we're not trying to improve it. We're not trying to make a dent. We are our goal is to eliminate Hep C from our community. Our community is not just natives. So I put this up. 45% of the people we see are Grand Ronde natives. 21% are other natives, and some of you may not know, but any Native American can go to any Indian Health Service clinic anywhere in the country and get care for free. Anything that we can do, I forgot to say we have lab and x-ray. Anything that we can do, they get for free. And one of the issues that we had when I started this program just about a year ago, I had come to this conference a year ago, and we were just getting started. But when we started, our hepatitis antibody, or Hep C antibody test was a send-out lab. And as we were aggressively trying to find our baby boomers that were other natives, they would say, hey, we're not paying for the test. So along the process, we got the ORVHCollective that we brought in, and then we called all those people back, and it was a huge part of getting tested. So the other thing is just we're primary care. A year ago, we had no hepatitis C program. We were just starting when I came here, so I'm briefly going to talk about what we did. When I started this, I did not expect to get so much enjoyment and professional satisfaction from doing it, but it has really surprised me. I feel like what we're doing is so important. It has been fun. One of the first things that we did was build a team, and I have really enjoyed, we have people from, the first person we got were IT people to help us go through our electronic medical record, figure out how many patients we had, figure out our screening rate. Then we got the lab people involved. We have the pharmacy. We have case managers. I think I have pictures of everybody. This is our team. Our administrator is very supportive of our program. So one of the things that wasn't mentioned earlier, that many of you know, Native Americans, when you look at hepatitis C by ethnicity, we're number one in Oregon and all across the country. When you look at mortality, Native Americans are number one. And the people in Grand Ronde are aware of it and really care deeply about it. The other interesting thing about our clinic is we have our own newspaper. So I was thinking about Maurice, who spoke earlier, said he didn't like numbers. I realized a lot of what I've done in this year is to take numbers, but figure out how to get a buy-in in the community. And the fact that we have a newspaper, I've been writing articles all through the year. Imagine if HIV Alliance, all their people were reading a single newspaper, or Andy's patients. We have that. I've written articles, I've done podcasts, and so it's been fun getting the buy-in. That slide didn't work. One of the first things that we did, so I did a training with Dr. Jorge Mera from the Cherokee Nation. So everybody here knows Oregon is third highest prevalence of all the states. Number one is Oklahoma. And he's an infectious disease doctor. He committed to elimination in 2015, and he has set up tribally led, I think it's the only tribally led echo that we're a part of. And he has been reproducing his vision to over 70 different tribes, and we're just one of them. I think they're actually up to 100. But the first thing he said is, before you do anything good, figure out your prevalence and your screening rate. There we go. So we started out, and it was terrible. Slides aren't doing. Our screening rate was 14%, and our prevalence when we figured it out was 1%. So we immediately realized that this is probably not right. In our electronic medical record, in the first run, we were using every person that was ever in there. And we run urgent care, and many of the people weren't our patients. So people had told us that a widely accepted way of doing it is only counting patients that have been seen twice in 3 years. In the second, so I committed to every quarter to figure out what our screening rates were, and while I'm doing this, I'm working with the providers, I'm writing articles, we're doing things, and our second prevalence, so in the first, anytime you work on a quality measure, and I know a lot of you know this, the first time you go through, you improve your numbers quite a bit by figuring out these people have died, these people moved someplace else, these people are not our patients. But this is just a review of what we did in 1 year. So in 1 year, we went from 14%, which might have been a little low, to 67% of screening for our baby boomers. And I realized you can't treat people that don't know they have the disease. Our prevalence rate, I think I have that, our current prevalence rate, which I think is a lot more accurate, is 3.6%. And that matches a lot closer to Ann's numbers. So each time we did our numbers, besides getting better and getting people treated, our numbers got better. So, we had to set up this thing. We have 5 physicians at our practice, and we set up a thing where I went through training, and all the other doctors refer to me, and then I do the workups, and I present people at ECHO. That took a little bit of work getting that worked out. This is Dr. Mera. He's really amazing. He's in Washington, D.C., receiving a national award from the Assistant Secretary, Karen DeSalvo, in 2016 on National Testing Day. And when When OHSU does echo, which is wonderful, and I think way more primary cares, it's a lot educational, and I think it's for 6 months. When we do echo, we're lifers, and we continue to present cases and share education with each other. Dr. Mir initially was doing echo with the University of New Mexico, and then they got the idea that they wanted to do a tribally led one, and the University of New Mexico had wonderful coverage in the southwest United States, but not a lot in the northwest and not in the plain states where he's from. So our echo has really done a wonderful job in those areas. Getting medications. When I started the program, I didn't realize you cannot get DAAs from OHA unless you get credentialed. And when we first started, they pretty much sent me this letter like, hey, we are not giving you any pills whatsoever till you jump through some hoops. So they weren't that difficult to jump through, but we did get credentialed. They do want to make sure that you're doing certain lab testing, that you're reporting your results back to them, and that we have case managers. And we have 4 RNs, 2 are on our team, and they contact the people that we're treating every week, besides the visits that we do. So I talked about the case managers. This is just a brief thing. This is the national genotypes, and these are our numbers, and they're almost identical. I separated 1A and 1B. If you put those together, you get 71%, and here's 73%. So here's what we did in our first year. We worked up 36 people. We have 5 people that are at SVR. We have 5 people that have completed their treatment, and they're just waiting for their final lab. We have 2 people that we've sent out. 10 people are either waiting to get treatment or to be presented at echo, and a lot of these are low fibrosis scores that we've kind of are saving up. We have 1 person that did not complete treatment. So interestingly, some of the biggest problems we've had in our Hep C are people with encephalopathy. So this person, when we started out, we did not realize they had encephalopathy. That has interfered with this person's care. The 2 people we sent out have encephalopathy. I have 3 people that we worked up who just are not ready. 2 of them have encephalopathy. And 1 of them is drinking 18 beers a day, and actually after January 1st, we will call that person up and get them treated. One of the things I've told the people, when we have worked people up, I said, we will not stop working until we get you treated. And initially, getting medications was difficult. The pharmacists have helped us a lot. We worked really hard with patient assistance programs, but we've told people we won't stop. That's not supposed to make a noise. That says I'm almost done. I tell them that we won't stop until we get them treated, and we've pretty much gotten everybody treated, and with the new OHA rules, which are wonderful. So real quickly, we had a big event on National Test Day last year. We spent over $2,000 on it. I think it was really well received by the community. One of the things we did was this t-shirt. That's what we spent a lot of the money. Jeff, by the way, is sporting one of our t-shirts. When I was here last year, I saw Lauren was wearing, she had a blue shirt that said, "Get tested, get cured." And it really struck me. I thought, on some level, hepatitis C care is that simple. Get tested, get cured. It really impacted me. And so anyway, in the tribe, we love everything we do involves Indian culture. So I wanted to take her idea and include some Indian culture. So we came up with some Salish art. And then on the back is a saying in Chinook Wawa, "Hayu monk skookum in Saika Tilakam," which means making our people strong. So it was hugely successful, and we got a lot of people involved. We totally copied the Trailblazers and had a Where in the World contest. You may think, hey, why do t-shirts matter? But this is taking numbers and getting people to buy in. The other thing, Lauren being a caring ambassador, every t-shirt I gave out when we were speaking, I said, you are now our ambassadors. So I'm talking about primary care. We need to treat Hep C. We're preaching to the choir. The message needs to get outside of this room. But When we were doing this, I kept telling people, you're ambassadors. You need to tell the people that you love, that your family, that aren't coming in, this message. So I'm going to show you some quick pictures. Here's a t-shirt that made it to the Rose Festival. This one made it to Crater Lake. This is Dr. Hull, one of my partners. This is 20 miles off the Depot Bay. OHA's own Jeff Capizzi in Atlanta at the CDC. This is one of my favorites. This one made it to Hawaii. This one actually won the award. I don't know if anybody's familiar with Playa del Carmen. It's in Mexico on the Caribbean side. So on the right is Maria. She's one of our case managers. So they wore their t-shirts. They actually had to snorkel underwater into this cave. They're actually in a dark cave taking a picture for you all to look at. This is me in Oklahoma City. I met Charlie in Oklahoma City. There he is. Again, Native art, it's a big part of Native culture, and everything we do has it, and it's been pleasant for me. I'm a baby boomer, and when we were doing our presentation and our party, I played the song Wipeout multiple times, one, to keep people from falling asleep, and we just had the idea. I love the song that we are wiping out hepatitis C. So in our first year, I think we were very successful. Going forward, one of the things, this is my other message that I really feel passionate about, we need to do universal screening. We were not able to do it in our first year. We will not get Hep C controlled unless we're doing universal screening. Dr. Mara, somehow in Oklahoma, in Cherokee Nation, he screens every adult. I don't know how we're going to pay for that, but it won't get solved unless primary care involved, unless we're doing that. This next year, we're starting an MAT program, so we haven't had that available in Grand Ronde. We'd like to start it this year. We would love to do have a needle exchange. We have a medication drop box, but so that's it. Thank you for your attention.
For the sake of